Did we do that?
So they must have wrapped up.
And the transcription's on speak.
Yeah. People are following me and make sure they have what they need to get caught up. Remember this person? Hey Shelby, can you hear us?
Yes, I can hear you.
Okay, great. We're just testing the room.
That's okay. I'm sorry. I jumped on. I'm actually driving into the office, so I didn't want to miss it.
Oh, no,
But I
it's
can-
actually perfect. No, it was perfect because we wanted to test this anyways, because we have the owl and we're in a new room, so.
Yeah, all is good. So I can hear you.
Okay, great. Okay, great, thank you.
You're welcome.
There we go. I guess that's a good sign.
Yeah. Discover slides.
I'm assuming we could probably turn one of the lights off down. Did they do that on their side? The
Yeah.
light, so I would need to do the lights from the top.
Yes.
That would be,
All cards on the table.
Why not?
Yeah, sure.
What do you think?
is it one of the lights, is it kind of,
Oh, yeah, that's a good call. Yeah, it's easier to see, but it's a little darker.
okay. Yeah. That's good. Alrighty. So when I need to share that, these are what I need, right? On my side,
Right,
because if I needed to share, it would be the ones that we've already. Is it the-
or you can share your screen and then just pull up the PowerPoint. Or if you have those PowerPoints, so this,
Cause this is one of them right here,
oh, perfect.
and then that's the other one.
All right, sweet. So if you click on either of those, that should share your screen here.
Here, okay.
And let's click on one and we can test to make sure the remote still works. It should. Sweet.
Do I make them large?
Hey, Olivia, are you on the meeting right now?
No. Go ahead.
Yeah, we can just test it real quick.
Yes.
Thank you, thank you, thank you.
Thanks, Tom.
Hey, Carolyn, did you mean to call me?
How do we make that bigger? Like,
Carolyn.
bigger,
Well, I'm gonna see if whoever's anything can see that right now.
All right, I'm doing this.
Yes. Sure.
I'm sorry.
is that come off bigger? Oh, you're on the.
All right. You're old. Okay, so now I have to put that. It's wouldn't let me. Take off.
Perfect. So, Kristen, when we look at Olivia's screen, we're seeing the slides.
Like this.
Okay. The same as somebody's, then. You know, Henry needs to.
Oh, to like put this screen.
It's too small.
Okay.
I
So
just don't know how.
what we could do is we could,
Do you want to see what it looks like if I screen share?
Sure.
Okay. Let me see.
Oh, it's not first stop, right?
So I,
It's just weird because it's like presentation external.
well, it's still small because it's just my little window.
Okay. All right. So we can do is.
That I don't.
Yeah, I see the bus person.
Yeah.
Sorry.
So we're just working, but
Hey, Ed, hi, Kristen, how are you guys
Good.
doing?
we're just working how to enlarge the
Ah,
presentation,
yes.
that's all. Everything works, but
Oh, yeah, so did you want a place to somewhere on campus?
Oh, not the park.
But I think our body.
Oh.
I should probably, yeah.
If
Yeah, so, so do you want one that's consistent or? Okay, Spillbrook has, I think they've been at 12 spots that are sort of time.
And we're, could you me, I'm like, yeah, and all that. Oh, so I just want to bother and sure.
Yes, let me talk about more. Okay, so I think they have a few offices.
Okay.
And I can keep it.
As long as it's not bothering me, I'm gonna see. Okay, I just want to.
Yeah, let me find out. That's the superintendent, if there's anyone.
Thank you.
Yeah. Yeah, let me check. Thank you. Let me know over. Yeah, I think. Yeah.
Like, that's something very much. But I'm like. I go to like, yeah.
I mean, that's just it. It's fine. You don't know. You have to. I have to come down with everything like that. I think that's kind of clear.
Yeah, so if there is like a spot that's just hanging out there.
Yeah.
That will, I might be longer time.
Yeah, as far as I know, that's kind of what was our, it's like, that when they realized that people are gonna be on Teams meetings, and so you have to headset, obviously.
Yes,
There's. But I'll find out, maybe they'll stay actually. You know, but I'll let you
How
know.
many people have you had in place so far? Probably about nothing.
I think it was like 80, well, 86 after that initial.
Right. Yeah, maybe more.
I know, right? I'm like, numbers have been like, yeah,
Yeah.
but yeah. It's 86 too, probably.
Yeah.
Please.
Actually, when I have to go.
Oh,
Because you found us.
Oh my God, oh my God. How are you, Dad?
See, wait.
Oh my God.
Good.
Yes, one day, one day. Anything you can see, guys? Yes, that was perfect. Yes, I think you did.
Just, just.
I have flexibility.
Okay.
I said I need help. Right, there we go, yeah. Here's my camera. That's it.
Oh, wow. 10:50. Huh? Are we at 10:50? Oh, you could be here. Yeah, oh, no, you just have it out. Oh, no, we're just testing the, your presentation was just a test. It was just, we're just trying to.
This is what we're seeing.
This is full screen. Yeah.
Yeah.
Okay.
Is it what we're-
Yeah. This is my,
Yeah.
So if you're gonna need a smile, sure.
Because you're not. Yeah.
Careers.
Does that, I'll just type up if someone's in the chat.
Yeah.
So I'll mute people.
I am muting. Do you normally have like?
This is what I did.
Uh,
You do this little icon right here.
Yes.
So that's showing you which group you're sharing. So we go back to the meeting. So share,
Yeah.
screen window or tab. And then I just click the one in that meeting. So let's say you want to share the other one, the back one,
Yeah.
share. Now it's that guy shirt.
Yeah.
You had anybody access the, meeting on Teams?
Yeah. That shows.
Yeah, yep, this is what we'll say.
Okay, great.
And then if you wanna
Such a.
end it,
I love that.
well, I would let them know that they're all gonna have to connect to the Wi-Fi. Let me see if I went one of the sheets.
If you guys wanna, if you need to go onto the Wi-Fi, like, and then it's gonna work. And then I'm like,
Yeah, yeah, I've not done this before.
I'm sure.
We need to.
yeah, that's not fair.
Yeah, so what I told her is.
Yeah. Yeah.
You know,
Yeah, this is actually.
there's a lot.
Yeah.
That's like not. Must be telling me I need them.
No, I.
Oh, no.
I used.
I have. I'm a fan of since I said it.
Yes.
Yes.
So, and I can, but I just kind of.
Okay, I think we could, I don't really. Don't either, but. Go ahead, can I? Your purchasing case.
Yeah. I actually don't. It's like
Okay.
229,
Oh, kids going out of state?
438. I'm pretty good.
Everybody had.
Yeah, you can find the teams.
Teams, okay.
So here's the thing.
Welcome to your new.
Oh, look. What's the thing done, first way,
Any thoughts? You're all set?
okay,
Just kind of,
close out.
Yeah, that's what.
Need to configure, that's what I. Choice that, right, that's true.
Yeah.
say what, when you're.
For 10, 12.
The 10, 12. Check this to 12. I'll
Okay,
make sure this is good to go.
okay,
Yeah.
So I have to be upstairs to assist with something.
okay.
I'll try and grab my laptop. Access to it.
I mean,
For like 10 minutes, make sure you're good to go. Yeah. absolutely.
Okay.
Let's hang out back.
Okay.
So like Barry, that I've done a lot of work with Ron, and then we like very into
I have to take a team. And then.
So.
Ever getting a demo with this. And then. Upstairs. So previous case.
So that was curious that.
I'll be done here. Yeah.
You might be fine now, unless we should.
No, I think we're doing less of those check with other meetings.
That's fair. Yeah, so that's, that one is like, it's like a brand new case that's come up and like nobody knows about it. So that's when it's good to like, yeah, present it and then.
No, then we can also it's be. So, did you go to the super?
No.
Someone has to.
I know, yeah.
And then.
Right, right.
Does something, and then that prompts, that, to do something. That's what I was trying to. No, it's not you. Yeah, it's not sure. Just put that. I thought we talked about something. You know, it's on this one. That's what you told me this one. No. The supervisor, yeah. And then it was a great response. They're all set. I didn't.
I'm sorry.
I think you did that.
Okay, thank you.
They know if I'm sure the one we like was for how we look at it. They know. Good to see you.
I can only do so. I didn't think it was anything.
I've been on.
Okay, yeah.
Or just check it.
Yeah, for four.
I don't want anyone out there, right?
Okay.
Then he's just gonna sleep over. Sure.
I'm not working 37 weeks, so I can't do 37 hours a week.
Mhm.
But that's not me, I got it.
That's also. Okay.
No, I actually don't see a forum yet, so I'm just gonna give it a few more minutes for folks to join virtually. Give introductions.
We need that forum. And the number, the one.
Point distance constant, so I can take that there.
Okay, so this is.
Yeah.
I mean,
She's already, there's no more than,
Yeah, we got 7.
See.
Okay, so we are good.
Oh, here's Nancy Jerk, she's in the.
All right, everyone, thanks for joining us in our new and improved MAC room. Temporary. Thanks for everyone's flexibility and the changing logistics, and thank you to Kristen for managing all of the logistics and getting us set up while we're out of the prep building temporarily.
and our technical assistant.
Yes. Do
Thank you.
you want me to kick off introductions?
I just want to say good morning, everybody in the room and everybody joining us virtually. But we do have some new. We do want to do introductions. I'm Lisa Britzky Stevens. I'm the chair of the NAC. Maybe we'll go this way. Center.
Yeah. Roger Kelly, deputy on the co-chair.
Carolyn Richards, come from Medicaid.
Olivia May, and I actually just recently took over the role of Deputy Medicaid Director. David Shorty is going to be leading our Go North, initiatives for the Rural Health Transformation Grant. If you have time, you'll hear from him later in the agenda to give a briefing on that. So we're really grateful for his much appreciated leadership on that, and thank you for everyone's support.
Good morning, Henry Lippman, the state's Medicaid Director.
Good morning, Tennessee Madison. I'm the foster care manager for CYF.
Paulette Rowell, DHHS, BCBH. Kathleen Talbot, your virtual speaker for health.
Jenna Wilson, DCYF Policy and Regulatory Unit Administrator.
And Kristen Vinifrock, administrative assistant.
So moving right along, we have 4 rules on the consent agenda. We haven't heard from anybody hoping to remove any of those from the consent agenda. Olivia, forgive me, do we just vote on the consent agenda or we?
Can we just give a moment here? Does anyone
Yeah.
want to make a motion to take anything off consent? For the 4 rules listed on the agenda.
Hearing none, let's move along to review and approval of the November minutes. Hopefully all the members have had a chance to review those. I know November feels like eons ago. Do we have any comments or questions or corrections for the November minutes?
Are you hearing us?
What's that?
Oh, yeah, it's not just a sound check. Good folks hear us.
Someone on Teams.
We did
Yes.
test it earlier.
I can hear you.
Yes, we can hear you.
Perfect, thank you. So as there don't appear to be any comments or corrections for the November minutes, can we have a motion, please?
So moved, I move to accept the minutes.
Do we have a second?
Second,
Was that,
Is that Ellen? Ellen?
yes, that was Ellen, yep, I second it.
And all in favor, say aye. Aye.
Aye.
Aye.
Aye.
That was not 7 or 8 ayes, I don't think. Do we have everybody?
if you're a member of the committee, we really need you to.
Hi, this is Kara.
This is Karen Rosenberg. I'm going to abstain because I wasn't at the last meeting.
Thank you.
And
Aye.
City Engagement's also,
Aye.
I'm covering for Marissa, but I was also not at the last meeting.
Okay.
Aye.
Okay. Thank you. All right, Olivia, do you want to kick off the conversation about the MAC and BAC transition? I think we've
Sure.
got a lot to talk about.
Yes. Yeah, so just to recap, we're now in our quarterly cadence for the MAC, whereas before we were meeting monthly. We've updated our bylaw to reflect that, but I think we're still, just making sure we're in a process that works well for everyone who supports participation. In our last November meeting, we talked about our options for how to handle rulemaking now that we're on a quarterly meeting basis. And we discussed the department sending out rules by email in the intervening months and allowing folks to request by email to take something off consent or to hold a meeting or form a subcommittee if there are questions or feedback on the rules. So having tested that out now once, we want to make a recommendation based on feedback from the MAC, which is having our usual monthly time held just as like a meeting time option. So that when we send out the rules, if there's interest in discussing them, or having the sort of formal presentation of them, we sort of have a ready-made time on a monthly basis to use and set up a meeting that way. So I thought that might be just a helpful addition, since we're in this process now and needing to keep our rules moving, but we have a less frequent meeting. So I'll pause there and just see if there's any feedback or reactions to that idea.
Can I just also weigh in, to give some of the people who may not have, had the experience that helps to inform where we live
Sure.
here. We had a little bit of a hiccup, just last month when we had a rule that was going to rulemaking. And some feedback from the subcommittee, Cara and Carolyn, you're here, you lead a lot of that discussion. But from my observation, what happened for us was we did have feedback that we wanted to bring back to the MAC. And time ran short. And then because time ran short, I think we took action or recommendations, or we formulated a letter that really in process should have come back to all of you. And really the issue for us was timing. Because we didn't have a meeting schedule. And this rule was going to rulemaking before we convened again. And even before we felt like we could ask you all to come together and see, review the rule and hear what the concerns were. And so we talked about that. We got feedback, obviously, from those of us in the subcommittee who struggled a little bit with the process and came back to this notion that we need to hold these Monday meetings, this once a month, at least we could come back and have that on our schedule. But we can release it each time if there's nobody looking for conversation on something that's hot and needs action before we meet again. So with that being said, maybe Kara or Carolyn want to weigh in on that, but in response to, pull you all back to what Olivia introduced, which is the meeting schedule, are there any questions or concerns? Sorry about that, Olivia.
No, that's super helpful.
Can I even talk a little bit?
This is Carolyn Virtue. From my recollection, Kelly, what happened was the subcommittee worked on the objections that the subcommittee had to the rule, the full subcommittee. Cara Nicholson and I worked on writing a letter in regard to that. And then we sent the letter to the MCAC for approval. And paraphrasing, as it came back, it was that we shouldn't have written a letter and sent it for approval. I think the way we handled it was in accordance with the bylaws. And I don't understand how how a subcommittee is gonna work and what the level of micromanagement will be. And I think anyone who's gonna micromanage the outcome should come to the subcommittee meeting.
So I
So I
don't,
think this is why we want to surface under the new model, how the subcommittees engage with the full committee, because we have fewer meetings and fewer opportunities to have those conversations. And I don't want to dwell too much on the past. I think part of the hiccup is that the letter came with a request for a motion without any or approval without a motion. So I think that was some of the disconnect, was just sort of the process piece. I mean, what I would say is subcommittees may work in a number of different ways. They may be able to sort of work through differences with the program area and come to an accord, in which case the rule could land on consent and happily move along that way. I think the bigger question is when the subcommittee and the program area are not able to reach an accord, and then how, if it's an off month, does the subcommittee work with the rest of the committee to suggest or discuss that the full committee might write a letter in objection to elements of that rule? I think the ad hoc meeting being held on a normal Monday can hopefully fill some of that void. I think additionally, you know, I'm happy, and I'm sure Kelly would be too, to set up a call with subcommittee members and just sort of get brought up to speed on the work. And then we can look to the full committee to say, there is a request from this subcommittee that the full committee write a letter in objection. We get a vote on that recommendation. If that motion prevails, then we write a letter and we submit it. If the motion fails, then I think we do sort of what happened with the 805. And individuals who happen to be members of the MAC can submit an objection under their own signature instead of under the committee's letterhead. Thoughts or reactions to that suggestion?
This is Kara. The only thing I want to say, because that process was very unclear, I want to remind you that Kelly was at the meeting where we decided how we were going to move forward with that letter. But I certainly hope that having that time saved for those Monday meetings, that the issue that we ran into with the 805 can be avoided moving forward.
Totally agree. And, you know, as we've said from the jump about this, you know, we're figuring out how to do a year's worth of work in 6 meetings. And that's just going to be, we're learning as we go and hopefully continuously improving our processes to make sure that everybody gets heard and everybody has an opportunity to meaningfully participate. But obviously, the new design is so that we can have more meaningful engagement from consumers, and I think we can all agree that's great. And, you know, the intention is not to then mute or disenfranchise any of the members of the MAC. But we're gonna have to figure out how we do this with fewer meetings every year. And this was a great learning opportunity for us. And, you know, we're committed to making sure that we figure it out. And we get into a new comfortable process, just like we had for so many years before.
I concur that holding that space for the meetings monthly is a really good idea, because if they're needed, then they're there, and if not, then it's easy to let them go, but holding that space, I think, is imperative, especially during the first year or two of the learning curve.
Thank you.
Any other feedback on the monthly meeting idea?
This is Holly Stevens from NAMI, New Hampshire. I also agree with that. I know that there are areas that the MAC looks at that I know very well, and there are areas that I don't know well. And, you know, so as somebody who may not have an area of expertise in where a subcommittee is working on something, I might not necessarily volunteer for that subcommittee because I don't have the expertise to participate in that conversation in a meaningful way. That being said, I would love to have the subcommittee report back and say, this is what we found. This is how it impacts folks. This is how it impacts providers. And this is why we think we want to do what we do. And that's, you know, what I would hope to see from a subcommittee. And I appreciate the work of every subcommittee that happens here, the ones that I've been involved in and the ones that I haven't been involved in. But I do agree that keeping that monthly meeting space open so that those subcommittees can come back and report to us what the impact that these rules are going to have on individuals, non-providers, and on the system would be really helpful.
Thank you, Holly.
Anybody else?
You heard something in the chat.
So in the chat, someone had asked about the owl view, because I think it's sort of doing a funky split of the room.
Which did that at the Brown.
Okay, so I don't,
I don't really.
yeah, we'll take that back to the next meeting. I'm sorry that
Yeah.
the image is strange. I don't think there's anything we can do.
He just left, so.
It's a big room.
Yeah, but it's a good tip for our next meeting.
Great.
So do you mind if I finish up? Please?
Sure.
Okay, so we'll go ahead and put back up those calendar polls for the monthly time, and you'll just see them either be confirmed or canceled in advance of each instance based on feedback as we move along here.
And so would we then ask? So what would be the trigger to hold the meeting versus cancel the meeting?
So when the department sends out rules by email, if we get a request from anyone by email to discuss further or respond to questions that can't, you know, sometimes we get questions that are really easy to just say, well, no, this is what that means. But if it's there's a need identified to come together, we would set that up. Sometimes we have rules that are on a longer time horizon, so we can just say, let's just take it to the next agenda. But if there's a need to move it quicker, then we would take advantage of the next monthly time.
And what would be, you know, sort of the drop dead to get that, to say like, we're gonna have that meeting, is it like the Wednesday before, the Thursday before?
Yeah, that's a good question. I would say probably the Thursday before would be the drop dead, just to make sure that we have lead time for administrative meeting.
It's Carolyn again. I would add one thing to the timeline, and that is that the one of the things that set it up to not have enough time the last time is the department didn't notify the subcommittee that the rule was being filed with Gelcar until after it was filed. And I don't think once it's filed, the deadline for the hearing is a month. So I don't know if that helps or not, but the department might want to look at that.
Yeah, thank you for flagging that, Carolyn. I know we were gonna start listing there's like a web link to monitor Gelcar status that we were gonna include in those rule emails. But it's a good point that we want to make sure that the timeline still syncs up with enough advance notice.
I think that's a good reminder to all of us that, if there's a rule that we're particularly interested in, we might need to go find the information because we're not gonna have it necessarily smooth the way we've become accustomed to. So.
I guess the point is the way that we, the subcommittee, found out about the filing was through my weekly monitoring of the Delcar filings. So what I am asking for is a heads up from the department that would work with the timeline of the meetings, that the interim meetings that can be called.
That's fair.
I think I.
The 805 for me feels like such an outlier because it has been in development for 2 years, right? So I guess I'm trying to think about the way that most rules would be coming through versus an outlier. Not to say a heads up is not welcome, it absolutely is, Carolyn. But I'm trying to think of how we collaborate on a process that fits the way the majority of rules proceed versus some that follow a very different path.
Agreed, Lisa, which is why I was surprised when it was brought up today in regard to this process. So I agree. I don't think it even belonged in this discussion, but here we are. Thank you.
Well, the discussion was really about the Monday meeting, holding that monthly meeting.
Thank you for all the feedback. It's really helpful. And I'll take that back on whether it's the sort of notice lining up is feasible. And then I also wanted to share an update on the BAC. So we've had 2 meetings with our Beneficiary Advisory Council. We're still welcoming, further recruitment on that forum to build more representation from individuals who are themselves Medicaid recipients. And we really appreciated the input we've gotten so far. So as we go forward, the BAC will meet every quarter in advance of the MAC. And part of the intent there is for the BAC to identify items that should be brought to MAC for further discussion and presentation. So far, some of the topics raised, one is the federal changes to Medicaid that will impact our program in New Hampshire. So that is going to continue to be on our MAC agenda, tracking those changes and what we know and what we think will be effectively on our Medicaid program. There was also interest raised on the dental network. And so we shared some further data with the BAC about the dental network development. And then that's also on our agenda under department updates here, where we give updates on the adult dental program. Another topic that was brought up of interest is there were recently identified some adverse safety events with waiver recipients. And so once the department is sort of further along in a place to give a report out on that, we'll bring that to MAC for further discussion and presentation. And we'll just continue to, brief out on this meeting, what's being raised by the BAC, what we'll present here as a result. I think as we do get closer to things like Medicaid work requirements too, we'll be having the BAC review materials that are going to beneficiaries, and then if there's discussion out of that, if it's brought here, you'll see that come onto the agenda. Finally, the BAC, unlike the MAC, not every meeting is going to be public, and so we'll notify the MAC when we do have BAC agendas that are open to the public or open to broader participation. And we'll also post summaries of the meetings online. So just to kind of recap what was discussed and the major takeaways. Karen, I see your hand is raised.
Thank you. Why would the meetings not be public if they're federally required?
Yeah, they're not federally required to be open to the public, and I think the intent is to allow for the participants to decide, if they want to have a smaller attendance. People are expected to sort of discuss their personal experiences, and so I think it's meant to allow for like a more some level of privacy that isn't necessarily guaranteed in this meeting, since it's really open to anyone.
It creates a constructive identification as somebody receiving public benefits, and so I think the department wants to ensure that people can enjoy anonymity and not have their name and potentially their contact information associated with being a recipient out in the world.
Okay.
I'd like to stress the importance of that. This is Ellen, but I just want to stress the importance of that because I know there are people that were interested in attending that haven't for exactly those reasons. So thank you for being mindful of that.
And how is there more of an effort to get to recruit beneficiaries, and is there a way that we could assist with that? Because I understand there haven't been a lot of beneficiaries on that committee.
Yeah, we definitely would, if folks want to support recruitment, we welcome that. We'll recirculate. We have like a recruitment flyer material that we can send out again after this meeting. And so I just wanted to make it clear that we're still accepting, interested folks who are themselves service recipients.
Okay, and just one more question. When is the next meeting? In case we think of
I
people.
don't know if we have a schedule finally yet. I know Kristen's working with the BAC members. So yeah, it's not finalized yet. We kind of reach out to everyone individually to finalize the time.
And curious, Olivia, just as you're like trying to find interested people, have you all solicited members of advisory committees at each MCO?
We haven't, I did think about that. We could do that. Yeah, that's a good idea. I think part of it for me is balancing too, like maybe someone who isn't already participating on a ton of committees, but I think it's a good idea to let FCO committees so folks are interested too. So
What, 3-4 times a year?
their quarter, or the FCO ones?
Yeah.
I actually don't know off the top of my head their cadence, but we can certainly find out. And so Kristen, the next BAC meeting would be April or May, and
May, because we're meeting in
Okay.
June.
yeah, so
Our next meeting is June.
we're working on our May times, and we can let you know when that's scheduled. Any other questions, comments?
Do we have anybody from MAC who's on?
Yes, yeah,
We did have representation from MAC.
yeah, on the BAC, yeah. Yeah, I just want to thank everyone for your feedback and flexibility as we make this transition on our forums. It's much appreciated.
Before we move on to, the HEC 6420. Oh, sorry, I skipped.
Oh, yeah.
Sorry.
Oh, we all collectively skipped, or I did, my fault, sorry. Putting it out to the full committee, to request future agenda items. We're still carrying the direct support workforce. Future agenda item, but are there others that folks would like to see us add to that list?
I had the, I think it's a recreational therapy rule. It's came as a request to me from the OT folks. I did reach out to the department about it, maybe keep our eye on it, but may as well just capture it in future agenda items.
Okay, well, now let's move on to the proposal for HEC 6420 Medicaid covered services.
Hey, everyone. We have a PowerPoint that we can show. Just highlights, HEC 6420, which is Medicaid covered services, and it's primarily for residential treatment and foster care programs. I'm Kathleen Talbot from the Bureau for Children's Behavioral Health. Thank you. Dynasty Madison, from TCYF. Thanks.
Yep,
Thank
thank
you.
you.
So we're just gonna quickly go over this and see if there's questions that we can answer. Again, it's for residential treatment and foster care programs. We're gonna do an overview of changes, our stakeholder engagement, and then feedback or any questions. So you should have gotten the draft of the rule, and our next step is to be filing for FIS. So what are these services? These are the services which are allowable to be billed to Medicaid for, again, residential treatment, PRTF, psychiatric residential treatment facility, and then for foster care programs. Just a quick mention about foster care programs. This is different than kind of a general local foster home situation. These are for the services that are a part of a foster care program. Chauncey, do you want to just speak to what's encompassed in those? Like, what are the program models that we use at this point, 3 or 2, right?
Yeah, so when it comes to foster care programs, those are external certification. And we have a couple of different programs that we operate. One is individual service option, which we call ISO. We have an intensive ISO program, and we also have right now we have an enhanced foster care program. But essentially, this rule allows for us to have those Medicaid covered services for support and counseling and case management built into the model itself, so that agencies are able to operate higher skilled foster homes that encompass some of those identified.
Can you repeat that? What services are getting built in?
What services? You just like, clinical case management or family counseling. There is an aspect of psychiatric evaluations. So there's a number of different, it's a bundled rate. So there's a bunch of different things that they're able to do. That's all incorporated in the program itself. So it's designed to have all of those aspects right in place, as opposed to a general level foster home where we can kind of curtail and modify what's being supported.
By name, it's known as ISO foster care.
Oh, sorry.
Yep. So it just might be familiar to folks who have heard the term.
I'll hold my questions to your section of questions.
Oh, that's fine. And then, so we're working to renew and amend the rule. We're updating changes that have occurred as part of practice or as other parts of rules or state plans. We're updating the requirements for foster care programs to not include Medicaid time studies. So here are some of the highlights. In the scope, we clarified some of the residential treatment components, included PRTF, which was cited earlier, the psychiatric residential treatment facility, and we clarified foster care programs. Some of the definition changes we made, general updates, added new definitions such as BCBH, which is our bureau, care management entity, which operates our fast forward and high fidelity wraparound models, and PRTF. There's a few other updates as well, and that goes into covered services. So I'll get into that as well. Expanded the eligibility to the new program types, which is good. Then covered services, we updated the language based on current practice, and then added ABA for appropriate populations. The qualifications for providers, we added the PRTF. So this is really consistent from scope to the bottom of the rule. You'll see updates to PRTF, ABA. General updates to languages, included ABA.
Can we have somebody to mute themselves? Thank you. Sorry, Kathleen.
That's okay.
Need the slide.
Yeah, sorry. Requirements for examinations, added PRTF references, removed outdated services, and added documentation requirements. And then documentation of services, just updated some language. And then Medicaid time studies, remove foster care programs from that requirement, and then updated forms to be fillable. The payment for services, we clarified language and added PRTF, made payments aligned with the state plan, and then non-covered services, we updated references to include PRTF. There weren't really substantial changes to this rule. It really was a cleanup for the 3 primary components of ABA, PRTF, and updates to foster care programs, as well as any of the state plan changes we had already made.
So there's the concept that it's sort of all inclusive or bundle and it's including, well, specifically case management, because I'm trying to think of kids that are engaged with, or families who are already engaged with a case manager, for example, community mental health center, or a certified community behavioral health center that's required to provide them. But federal regulation prohibits duplication on case management. That's not new.
No, that's always been in place.
The fact that the service was embedded here.
Yes, there's been no substantial changes to the provision of services within ISO foster care or residential treatment. Those have been in place for decades.
All bundled.
Yep.
Great.
Just stakeholder engagement highlights. We've done quite a bit of work on internal department, crosswork between our different divisions. Then we had providers.
Excuse me. I thought I had my hand up. Am I incorrect?
Didn't see it.
I had a question.
I have my.
I had a que-
We just didn't see
Kathy,
it.
you
Sorry.
go first. All right, you go first, Kath.
Okay, I am not from your home school. I mean, as far as yes, I do receive Medicaid, but I do not, I mean, unless you have what it stands for next to it, I don't know what you're talking about. The only one I know on the previous slide was ABA, so apply whatever, because the only one I heard of. Because I cannot make sense of any of this. Like PRTF, I need a list of what all these things mean to make sense of this stuff. I'm just Kathy. I don't live in y'all's world where you can just speak. I'm acronym impaired. Never mind sitting in a wheelchair. This is driving me crazy. And right now, I don't even know why I'm sitting here. Because I'm so frustrated. As you guys talk in a whole different language. And I don't understand. And that's all I want to say. I need a list. That's what I need to participate. Thank you.
Okay, is it my turn?
Yeah, it is.
Okay.
Sorry.
Thank you. No. Thank you, Kathy. And I do agree that acronyms are really hard when you don't work in the given field. And there are acronyms on this page that I don't understand either. So I would just back up those comments. Sorry.
We
My
can hear you.
comment is more a question. And for some reason, I can't see the screen with the slides anymore, but that's probably on my end. But my question is in regard to defining care management entity. And my question is, if this is a Medicaid service, which is what I understood you to say, these individuals have care management from the MCO. So I'm wondering, A, is this a duplication of that? Or B, should it be called something else?
Let's back up for a moment. I think we're talking about a specific waiver program for people that have specific qualification criteria. So maybe we could start back there. In terms of the two big abbreviations that have been up there is PRTF, which I think they went over as psychiatric residential treatment facility. Let's pause and explain that a little bit for people. And
Thank
then,
you.
then ABA is behavioral analysis, applied behavioral analysis, and we'll take a moment to explain that too.
Happy to do that. So the services that we added to this rule are psychiatric residential treatment facility, and that is a high level of inpatient care provided at an inpatient or at a separate facility that provides residential treatment 24 hours a day, as well as inpatient psychiatric care, but it's not considered a hospital, an acute care hospital like we would consider like Hampstead. Although we do have one functioning at Hampstead, but it's a separate program model. And so what it's doing is it's adding that definition in those service lines into this pre-existing rule, which aligns with our state plan.
So PRTF as a formal recognized service
Yes.
is a relative recent phenomenon in New Hampshire. It's been something that's out there in other states, but it's basically if you kind of think about the least restricted environment to receive the needed level of care. And there are less restricted environments, but it's a step down from being in an acute setting.
Yep. And so this rule historically has covered those lesser restrictive environments. And this is updating the rule to include that environment that we didn't previously have in New Hampshire. Yep. And then and I apologize for moving so quickly through this. So the ABA, we do have programs in our lesser intensive and in our psychiatric residential treatment facility that do provide ABA. And we wanted to make sure it was included for appropriate populations in this rule because they have been using that and providing that. And we wanted to make sure that applied behavioral analysis was included.
So, and maybe we're going there, but, Kathy and others, applied behavioral analysis is a treatment modality for children on the spectrum and who have autism. So it's a very specific and narrow treatment modality. I know you said this, like for appropriate populations, I just want to make sure that our members know what the target population is for that service.
Yep. And so again, to highlight this rule, if you look at kind of the top to bottom, there were updates that were done in those categories, but it wasn't a significant amount of changes otherwise to this rule, updated language, but not really, it wasn't a rewrite or anything like that. I'm going to pause here because I want to see if there's any other questions to help explain anything that I did go over or back up.
I see, so let me just say quickly, my display of hand raising is different, so I realize that now, so now I'm seeing who's raising their hand. Joan's hand is up, and I don't see anything in the chat, so let's go to Joan.
Hello, how are you, everyone? I do want to thank you for that explanation. I did agree with Kathy. It was confusing, especially when you have people coming from other areas that might not understand all of these, and they're trying to think of how can we integrate our, especially oral health, how can we look at future programs, how we can integrate that. So I really appreciate the overarching view of what you're trying to achieve here. I did have a question about the Medicaid time studies. I don't understand what that is. I've not ever been involved in that. So if you could explain what they are and then why you removed those from these programs.
Sure. So Medicaid time studies we're still conducting for residential treatment programs. They are not necessary for psychiatric residential treatment facilities.
They are provider, not the patient.
Yes.
So just maybe go back to that.
Yep. And then I definitely will go into what they are, and we don't need them for foster care programs. So that was an update to the rule. But Medicaid time studies, what it does is it will take the provider and ask them to conduct analysis of how they're performing interventions for families or for youth. And so the staff are required to document moment to moment or in certain intervals, how much time they're spending on interventions with children or families. So that way we know how much Medicaid service is being provided with that child or with that family during the course of the day. So that tells us through a calculation and analysis, how much Medicaid we can, how much Medicaid time is devoted toward that daily rate. So that's what a Medicaid time study is.
Okay,
That helpful?
somewhat. I'm still learning.
On the Medicaid right now, I learn something every day, so.
Just to say, it's the good news and the bad news, right?
Thank you.
And there was a question out there, and I don't want to ignore it, that care management entity, when we define that, if we looked up one of the state statutes around our children's system of care, the care management entity is an entity by statute that provides high fidelity wraparound, which is one of our evidence-based practices, and it supports families. And in this context, helps support children and families while they're in residential treatment to work on shorter lengths of stay and have them return home. So it's really paying attention to targeted treatment and making sure that family and youth voice is a critical part of the admission to discharge and transition home, and that they're really focusing in on supportive transitions with that child's team. Am I okay to move to stakeholder feedback?
Don't see any hands raised or questions in the chat.
Thank you. So we had, like I had said, internal department involvement from various divisions even beyond this. Then we also had a core group of residential treatment programs. Those are our providers who really are the part of this rule that we focus on, as well as the foster care programs, who are an important part of this rule as well. We also have family and youth and advocate stakeholder feedback that we've requested. We'll also have, obviously, a public hearing as we get closer. And then we did already receive response back from the Office of Child Advocate with no comments. And we're waiting to hear back from NAMI, our care management entity. And we did provide a copy of the draft to a youth who's in residential treatment currently.
Can I ask one question about the timing of the feedback? So you're soliciting feedback. Can you just give us an understanding of like when people were engaged or when they're notified, and then what the, like you heard us talking about our cadence?
Sure. Yeah, so we reached out to OCA, NAMI, and the CME. I think it was in February, early February. The youth only received this maybe last week. It came from a very natural conversation with his or their residential director, who was saying that they're interested in kind of participating in these types of conversations. It was a great opportunity to send it over to them. And so we haven't received feedback yet, but we're not in the position of file this today anyway. So we've got some time to be able to get their feedback back. And then the residential treatment providers have been a core group to review rules with us for the last 2 years. And so they've been in the last probably 6 months, more focused on this particular rule. And then the foster care programs.
Yeah, we've talked about it off and on for months. We hold a monthly meeting with them, and those are things that we review, and they're able to provide feedback then or follow up if they have emails, specific questions.
And then I do want to highlight too, that the two on the bottom are the foster care programs, but the other programs that are also residential programs cross into the foster care program world. So it's.
Yeah, so like Easter Seals and Spalding Youth Family Services, they both have foster care programs that they're certified to provide care for.
Thank you, Kristen.
That's it.
For other questions or comments? This was originally on consent and somebody requested that it come off consent, so I just want to make sure that everybody's feeling like they have a good command of the content of this rule and, the purpose behind the updates and amendments.
Oh, sure, there's nothing in the chat. I can see a red dot.
I know, it's throwing me off too. but
Sorry.
I see the chat, There's nothing in the chat,
She's doing the chat, yeah, I know, I'm looking at
Yeah.
College.
and I don't see any hands for you.
Okay.
Well, thank you all so much for being with everything today.
Thank you.
Thank you very much. This draw.
It's gonna be, Olivia and Emily.
Okay, super.
I'll have a full emergency.
Yeah, we're gonna cover for Bob, and so we have a PDF version of the legislative tracker document. Kristen, I'm actually gonna share it, if it's okay.
Yeah, I didn't,
So I'm gonna share a version that is in Excel, but it has highlighted sort of items of interest that the department is tracking. I will zoom in as well, make it a little more readable. Can folks see my screen? And Kristen is now back on like kind of,
Yeah.
but folks can see the Excel document.
yes.
Yes.
Okay, thank you. So again, we'll send this whole thing out to the group. But just to view some of the highlighted items. The second one, SB 134, we'll speak to a little bit more in a minute too, but this is a Senate bill that was retained from the prior session and amended more recently regarding work requirements, and now the state is to implement those for the Medicaid program. This passed the House and Senate as amended. So we'll speak to it a little bit more when we give our broader update on work requirements. Some other highlighted items regard to long-term care eligibility. SB 506. Oh, yes, sorry. SB 506. Yeah.
So 506 was, in the Senate, was a potential bill that, was going to be used if 134 was not something that they could agree upon between the House and the Senate. I'm trying to remember whether it was ITL or whether they saved it in case they need to do something later in the session.
It does refer to by us on the tracker.
Interim study, so that they left themselves the option for a legislative vehicle in the future should they need to make changes.
Yeah. We're also tracking legislation related to coverage of GLP-1 medications. This goes beyond Medicaid, but the Medicaid program recently made changes to GLP-1 coverage, which we had shared with the MAC before. So I think our interest there is just making sure it aligns with our current coverage guidelines for GLP-1s and Medicaid.
I think that we're talking with the sponsor. I think she may be attempting to get the policy in place and to then get an appropriation next budget. Basically, it's restoring it to a lost something.
There's a House bill that seeks to repeal the pharmacy copays and premiums passed in prior sessions. That has been ITL'd, which I'm forgetting what ITL stands for, but
It's an expedient to legislate.
an expedient to legislate. There's a House bill that we're tracking related to minimum nursing home staffing standards. There's another House bill that's seeking to include diapers as a covered item under the state Medicaid plan, not diapers for, sort of medical incontinence, but diapers for babies. This one's tracked as late on table. Just looking to see if there's any other ones I'll speak to briefly. There's a House bill related to healthcare use of artificial intelligence in making clinical determinations. This is currently off to pass as amended. And the rest, I think I don't want to speak to incorrectly. Without Rob present, but we'll send this out unless you want to speak to either of these centers.
663.
Sure.
663 is basically a bill that seeks to address the rate setting results that occurred in effective January 1st, where there were initially a larger than usual percentage of nursing homes that saw a rate decrease. There was a $5 million appropriation that was stripped from the bill. It was to be targeted at certain facilities, not all facilities. The end result was to create a working group to study the existing rate methodology. And that was part of the bill originally, but that's what remains at this point. And I think it's passed HHS and Senate Finance at this point. And I think 615 may be related to a number of different things, but the SNAP eligibility was about, I think, restricting what could be paid for under SNAP, like candy and soda type of things. There was, I think, an interest from a number of different angles on that component. One related to the cost of the program, the second related to incentives for them future scoring of the rural healthcare transformation grant. It's one of the areas that the state can gain more funding under that grant.
I'm going to stop sharing so that I can see if there are questions. And like I said, we'll send this out. And if there are, feel free to send by email any questions that we can circulate back to Rob.
And then 2 bullets and the agencies.
Yes, I'm gonna go there next, but just on the state legislation, Karen, I see your hands raised.
Thank you. I don't remember the number, but aren't there 2 House bills that I think may have passed or got out of pass recommendations about SNAP and one regulating sugar and one having to do with categorical eligibility? Am I missing something?
No, I think you're right that there's HB 1773 relative to food and drink purchased under supplemental nutrition assistance program. That is listed as ought to pass as amended out of the House. And then the other one is sorry. 1797, House Bill 1797 says that it's relative to eligibility for a few programs, including SNAP. I'm not sure if that's one of the ones you're thinking of, Karen.
I think that's it. I guess it has like similar, I didn't know if that also interfaced at all with like the Medicaid work requirements and tracking folks, or maybe not.
I don't believe it does with Medicaid work requirements.
I think it may have had some component related to SNAP work, SNAP work requirements and what would be acceptable on an attested basis versus on a verified basis. Honestly, that part I'm not that familiar with, Aaron, but.
We'd be happy to take it back, Karen, and just do sort of a summary across the 3 SNAP related, the 2 House bills and the 1 Senate bill that deal with SNAP eligibility and allowable SNAP items.
So we'll probably talk about work requirements a little bit more, but just to put a finer point on, we are working very closely with our SNAP colleagues in terms of how we design, our communications and the eligibility process there. So a lot more to say there, I think, and more in the future.
Well, did you have more to say today?
Yes.
Yeah, I was just looking on the agenda, it's been quite
Yeah, it'll be in this agenda. I know, I just wanted to hit legislative, state legislation first, and then we'll go there.
Thank you.
Yeah, no problem. Any other questions on state legislative tracking?
So I'm just gonna cover a couple of small bullets underneath.
Sure.
So recently, we've been following the news, the national news has been a lot about Minnesota and fraud in the Minnesota Medicaid program. In the HR 1 bill, known as the One Big Beautiful Bill, also known as the Working Families Tax Act, and so it's a bill that has 4 names to add to the confusion of it, but we're talking about the bill that was signed on President July. That contains a lot of changes, but in that bill were things to strengthen fraud, waste, and abuse. And we did include at the bottom of page 3 a definition of what those things mean, so that you'll have that as a resource. But the thing I wanted to lift up today was in the State of the Union speech, there was discussion of fraud, waste, and abuse and what's going on at the federal level. And a number of states in the region, most notably Maine and Massachusetts, were brought up in the president's remarks. And generally, there's been a focus on home and community-based services and ADA services that has come out of that. There are also 2 congressional committees that are doing inquiries into a number of different states, asking them to provide information about what they're doing to reduce fraud, waste, and abuse. New Hampshire has not received a letter as of yet from the federal government or Congress. But I would say that that also that CMS has issued a request for information. Sometimes we call that an RFI by abbreviation. And due to my Boston accent, it's an R. And I request for information on what more can be done to strengthen program integrity, which covers that space. And so they put out a solicitation at the end of February on that. And also there is the request for information is called Comprehensive Regulations to Uncover Suspicious Healthcare, or CRUSH. And so there's a new acronym for us. CRUSH is about reducing, looking into suspicious issues that are happening in provider and beneficiary access to services. There's also a provision in the Big Beautiful Bill about states when they do audits, which are called, and I can't remember what the acronym stands for myself, but they're called PERM audits. They're done on a 3-year cycle in every state. That if a state has results below a certain threshold, kind of like what's going on in the SNAP area, there's an error rate under 3%, then there's no penalties. The act does away with that threshold, meaning any penalties, any findings would result in repayment to the federal government. That I think goes into effect in a few years. It's not immediate. 29 is what it states, federal fiscal year 29. We're currently in the current audit cycle right now, so it would be just as our next audit cycle would be in that period of 29. Then also published by CMS, but a collaborative effort of DOGE, the government efficiency initiative that you may have that was in the news a lot earlier in the year or end of last year. A database that's intended for, anyone to do, examination of, historical information coming from Medicaid programs. It doesn't cover every part of the Medicaid program, but if, for example, there are no inpatient hospital, services. But, that the intent is to, you may have heard this term in crowdsourcing, which is just allowing anybody to do something to look at Medicaid data by state. It's the data that they pull from is from the statistical information that states provide, which isn't always, in our experience and others, the most accurate information, but it's all to say that there's going to be a lot more scrutiny on providers, the state, being beneficiaries with respect to fraud, which is the intentional abuse, which is typically unintentional. And then waste is more, it's an undefined term per se, but it tends to mean typically overutilizing or underutilizing the service that results in extra costs. So there's nothing specific today, other than I think, you know, as you're listening to the news or following things, it's, I think, important for you to understand that I think this is an up and coming issue that we'll have more to discuss at future meetings. And take any questions.
See Joan's hand is up.
Yes, thank you. Hi, thank you, Henry. I guess what comes up for me in this idea that you can outsource to outside entities for data collection and surveillance, is that going to protect data, you know, protect beneficiaries, protect intellectual property? I guess that's just a concern that I would raise here.
There's not PHI in the data, it's more on utilization and billing patterns. So, you know, if there's
It's expenditures.
it's expenditures based on billing codes,
And it represents about a fifth, they estimate, of total Medicaid spend.
like nursing home billings and hospital billings are not part of this database.
Yeah.
So for Joan, like in my shop, we have 5 codes for our med staff to bill. I watch those codes like a hawk to make sure they're blending, they're billing across the codes and not always billing a level 5, the highest code they can bill. And if I see somebody, or even just always billing a level 3, it tells us first education, and then continued monitoring might be indicated. So they're doing the same thing. They're looking at it more aggregately and looking for trends and looking for patterns that might say, yeah, they should be doing something different there.
They published this database, and then I think last week I saw that they had taken it down for further construction. Well, I'm not sure it's even up today, but it was published with a big splash in February. And it is what you said, looking at for certain levels of intensity of service, that they're looking for what they would call a normal distribution, and one that is either too far to the left, meaning too low level, or too far to the right, level, high level. When you mentioned a 5 of the code, that's what that's one of the things that you could see with that data potentially.
I think I maybe saw Ellen trying to say something, but I wasn't sure.
Yes, hi, thank you. I seem to be unable to figure out how to push the button for raising my hand. It's not recognizing it this week. But anyway, I just want to say that it's my understanding that so far only states that have Democratic governors have received these letters. And I've been told by somebody who supposedly is in the know that that will continue to be the case for a while, but of course that doesn't mean it will be the case forever. But I think in the moment, you know, we have time to prepare in case it does come down the pike. But because we do not have a Democratic governor, we're not in the sights at the moment.
If there are red states, and I think red states, being Republican states control versus blue states Democratic control. There are states that are red that have received those congressional letters and it is
I'll also,
Interesting, okay.
I'll also be, I'm happy to share, or willing, not happy, willing to share that Medicare, entities and Advantage plans, they're all doing the same thing. So they don't come from the government, they come from those private contractors that insure members individually. But they are, looking at a lot of trends, they're doing a lot of education, they're asking a lot of questions, but they are, more intensely engaged from that perspective.
I think that the concern, the pendulum goes one way and the other way. And so the concern from either a back perspective or an MAC perspective is the impact on providers and beneficiaries and also state funding. And so I think that's why I just wanted to lift it up. It's not draw a conclusion today, but just to create awareness and do something we'll probably spend more time as a nice good back.
Yep, good idea.
I'll move next
Thank you.
to premiums and work requirements, but before I do so, any other questions on covered so far? Okay, so as we've covered in prior meetings, our House Bill 2 directs us to implement monthly premiums for being enrolled in the Medicaid program for two different populations. One is households with children above 255% of the federal poverty level. And the other is for the Granite Advantage population between 100 to 138% of the federal poverty level. Neither of these populations have premiums as of today. The first step in the process for both really is to clarify the policy guardrails that are allowable for us to implement them. So we've been in conversation with CMS on both of those policies to clarify some different allowable rules that will inform the state plan amendments or other vehicles we ultimately submit to make it effective. So at the MAC, you'll see, what we ultimately submit, but before we can do that, we've had to clarify some things with CMS. So for the children's premiums, because of the continuous enrollment requirement, in other words, children have to stay continuously enrolled for 12 months at a time. It's presented some questions for just, when is it allowable to require payment of a premium to remain enrolled? We actually just got some additional information from CMS on Friday that we're working through. And so I think, likely in advance of our next meeting and then for our next meeting, we'll have the actual state plan amendment materials for enacting that policy. But as of today, I don't have an effective date to share. For the Granite Advantage premiums, unlike the children's premiums, this will likely not be done through a state plan amendment. Based on conversations to date with CMS, we think we will likely need to submit an 1115 waiver, which is slightly larger lift to pull together. And unlike state plan amendments, has a less guaranteed review and approval timeline from the federal government. So that is what we're working through now, is just clarifying what would need to be included in that 1115 waiver and what the likely approval timeline might look like, because that will of course inform the effective date of the premium. We can't collect until everything's approved. The reason why it's a different thing, it's not a state plan amendment, is the premiums for Granite Advantage will overlap is starting in October 2028 with the federal requirement that we implement cost sharing. In other words, co-pays or co-insurance for certain services. That's something we have to do under OBBBA, One Big Beautiful Bill Act. And so that just makes it a little bit more of a complicated road policy-wise to set it up. We will continue to update this group as we learn more, and certainly as actual submissions are final and ready for sharing. Any questions on premiums?
Yes.
Go for it.
I'm sort of a broken record, but, you know, the last couple times I've asked this question, there wasn't really enough information available yet to meaningfully respond, but, I'm just curious, you know, I'm sure you all have estimated how many households would be potentially subject to the premium. And again, because I lived through when CHIP became an M-CHIP and we sunset premiums, the cost to implement exceeded what we were likely to bring in, and it was a barrier to enrollment demonstrably. So I guess my question is, do we have enough information at this time to determine that, you know, because that was a long time ago, 14, 15 years, right? So the technology may have evolved such that it's not as big of a lift, but I guess, you know, I want to make sure that we're not throwing good money after bad. And, you know, what, if anything, can be done to ensure that the imposition of premiums does not become a barrier to enrollment the way that it was in the aughts?
Yeah, that's a great question. So I'm gonna talk mostly about children's premiums, just because I feel like we have more information there today than we do about Granite Advantage. For children's premiums, we did get clarification from CMS on the allowable premium amounts, you know, which impacts like how much revenue we expect to collect.
Yep.
And so that is, you know, below the legislated amounts, due to CMS requirements that were not identified at the time of legislation. The amount of households impacted, I can get you as follow-up an updated number. I know it was around 8,000 when the legislation went through. It is lower today, but I don't have the current number in front of me. So both of those things will negatively impact the total amount of revenue that's possible to collect. But so far, we've not identified a prohibitive cost to implement. We're still working on the implementation plan. We're sort of focusing right now on the eligibility system, which has to be updated, and we haven't had prohibitive costs there to at least get started with setting up the eligibility rules. And then finally, I'll say, for it not adversely impacting ability to participate, I do think the 12 months continuous policy does offer some protection there. So if you're a new applicant, our understanding to date, you know, based on conversations with CMS, is you pay 1 month to open. And we would continue to seek a monthly premium, but it would not be, it would not result in termination.
As you get,
Yeah.
there's no continuous
For 12
enrollment.
months, yeah.
Yes.
So I think that's one sort of, you know, safety net, and then another is that we are definitely planning to have, and I'm blanking on the like technical CMS term, but basically waiving premiums for extenuating circumstances. There will be a process for that too, and that'll be part of our policy, like the rules that we present will be like, what are the circumstances in which premiums can get waived? So I think like the easy example to think about is a child in the course of treatment. If they're coming up on their 12th month, you know, that would be a situation where I expect we probably waive the premium requirement to not interrupt like an active course of treatment.
Does the big beautiful bill prohibit premiums as of October 2028?
It does not prohibit premiums. It's really more about how to compliantly implement premiums alongside cost sharing obligations, or whether the existence of premiums could waive the requirement of cost sharing. Those are the sort of policy questions we're working through. Because in Medicaid, if you think about the whole program, any cost sharing, whether it's premiums, co-pays, all of it, it all interacts like from a policy perspective. So that's why.
And eligibility perspective.
Yeah, but I just mean from approvals, you know, touching when kind of, you have to touch everything and make sure it all works together compliantly. Karen, I see your hand. Oh, sorry.
Yeah, in the go forward, right? I would hope that there would be an effort to monitor the families, so like your example, they're new to Medicaid, right? They've passed all the eligibility hurdles and they never enroll. And that's a strong indicator that, you know, because the only thing they have left to do is pay the premium and they never enroll. The premium is serving as a disincentive to enrollment. So I feel like that's a really important thing to monitor, as is, and again, this was done in the way back. The families who pay that first month, but then don't pay, right? Because that gives us a lot of information about, you know, are these tools working in the way that they are intended or not? And so please take it in the spirit in which it's offered. I worry.
I will tell you, we will have a closure reason, you know, that will tell us, did someone close for not paying a premium? And so that should give us a pretty strong, and just because of how the rules work too, you wouldn't be charged a premium unless you got through all of the other requirements and those were confirmed.
Right.
So I think it will give us a good sense of who's closing solely due to non-payment of premium.
So I think one of the earlier questions, I'm not sure we addressed.
Okay.
But in terms of the number of children you think is subject to this, so there's roughly about 87,000 children that are currently enrolled. I think we're talking about somewhere between 5,000 and 8,000 children at this point.
Households, yes.
That would have children that would be subject to this. And also keep in mind that compared to the Healthy Kids Corporation, this doesn't have any premiums until you're at 255%, which is what about half the states in the that how to begin with. It's not to say it's still a challenge for them.
Yep. Karen.
Thank you. I think you started answering this question, or think, Olivia, but I'm wondering with Granite Advantage and like where my understanding of the OB3 is that it included some carve outs for premiums for cost sharing so that like preventive services, I think substance misuse, maybe some other services or emergency room visits that were bona fide emergencies were carved out. So how does that work if there's a premium? And is that, I'm sure you're working through that, but I'm curious about how what your thinking is about that.
Yeah, you're right.
As I say, your cost sharing, you identify as none at federally qualified health centers, none for mental health centers, generally none for primary care. And for emergency use, that's truly utilization of emergency room is no cost sharing there. The cost sharing is limited to a maximum of $35. It can't be zero. What we're trying to work through with CMS is the understanding of whether, as was said earlier, whether we could use the original plan, which is premiums. The advantage of premiums is that cost sharing amounts are really shared among everybody, not just the people who are utilizing the service. And it's less abrasive to providers in terms of having to do collection at the time of service. That's why I think we recommended when we asked to come up with an approach that premiums, I think, are the better way to go in terms of shares among all beneficiaries, it's only those that sick, and it is less of an issue at the time of business.
I'd also just add that, you know, we have excluded populations for cost sharing, like waiver recipients, and just due to the populations that are.
They have Granite Advantage, Canada waiver is what we're referring to.
Well, yeah, just clarifying that for Granite Advantage and the children's population, you know, that go, those sort of protected populations for co-pays, some of them would still persist. So we can clarify that too.
And their limit, there's a cap on how much one has to pay to 5% of the family.
Quarterly household income, yeah.
Yeah, I think that tracking was one of the real challenges in.
Yes, it is. So, I mean, I think, this isn't going as fast as we thought in part because CMS has a lot of work to do in terms of implementing that whole bill and they're spread over that as well. but we're making progress.
Is there any, like, I understand there's, the protection for children, the continuous enrollment, is there any kind of protection for people who would be enrolled through granted advantage or waiver for extenuating circumstances, that you were talking about?
I think we would consider that as part of the policy. Yeah,
We haven't done any work on that part though.
yeah, that's an earlier stage.
With children. Children's actually has an earlier implementation rate.
So in all of this conversation, is there more to say about the work requirements?
Yes.
Okay.
Sorry, I know we're running
You
the.
can tell that I'm really anxious about it.
On the agenda, but I do have a couple slides on work requirements. All right, folks can see that. Great.
Yeah.
So just at a high level, I wanted to go over, what are the milestones ahead for the department to enact the work requirements for Medicaid, and just to refresh, I know we've talked about it in prior meetings. One Big Beautiful Bill Act requires all states to implement work requirements for their expansion population, which here we call granted advantage. And then, as Henry mentioned earlier, there's also a state bill that we are anticipating that, kind of reaffirms that we need to comply with these federal work requirement parameters. So the effective date is January 2027. So looking from now through then, I wanted to recap what some of the work we've done already, what's ahead. We have the first two items really speak to CMS touching base with all the states on really the IT bill part of all of this, because I think as everyone appreciates, this has a big impact on all states' eligibility systems and what the eligibility system has to do and track to ensure compliance with work requirements. So we've kicked off some efforts with CMS that all states are participating in to kind of track our project plan. How are we going to implement that? What's our general timeline? And we are meeting with CMS regularly on just that IT build aspect of the requirements. Then you've got the policy side, right? So what are going to be the policy guardrails for these work requirements? A lot of that is going to be defined in federal rule that we anticipate by June of this year. So really all policy between now and that federal rule is kind of our preliminary understanding, subject to any kind of new policy that the federal government may define for us in June or maybe earlier, we'll see. We also have on here contract amendments. So like I said, because this has an impact to our eligibility system, we will in a future GNC meeting likely be presenting a contract amendment to implement the funding that's available for those system requirements. On the state plan amendment, so all states will use a state plan amendment to enact this. CMS is going to be providing a template for us to use. So we can't submit that SPA until we have the CMS template to submit it, and we expect it'll probably be on a very tight turnaround once we get that template. So back to kind of our like monthly cadence conversation, I think it's very likely that we might be looking to do an ad hoc meeting once we get those final templates from CMS.
So Senate Bill 134 requires us to prepare that within 30 days of publishing of that. The final rule, interim rule implementing federally in the Big Beautiful Bill has a date of no later than June 1st to publish those rules. So they really can't develop a template until they have the rules with which to do it. And I would say just a minor adjustment to what we were saying. Not all states are using the SPA. Some are doing the 11-15 approach if they want to start earlier. There are a couple states that are doing that or want to deviate from what was passed. And the states, I think there are 41 or 42 states that have Medicaid expansion at this point. So the 8 or 9 states that don't have it, like Texas, Florida, they don't have to do this.
Yeah. That's a good point. We also anticipate state law being presenting that state plan to our fiscal committee. And we talked about the 30-day turnaround. And then there will also be quarterly and annual reporting obligations defined by any state legislation that passes and any federal rules around reporting. Then, once we get that federal interim final rule, we will be looking to finalize our state administrative rules. So summer is going to be busy. We're probably going to be moving pretty quickly to enact those administrative rules once we have the final federal parameters. And then the base required member noticing begins September 2026. But ahead of that, we anticipate doing, broader stakeholder outreach, broader communications. This is really the more formal, system noticing that would start in September 2026 for those individuals who are going to be subject to the work requirements. And then, from there, it's finalizing all of the system aspects and getting through our jail power approval administrative rules. On the next slide, I have just a visual, which I think just puts it more in a timeline view. And so the way I would summarize this is really June through September. It's going to be the very busy season of finalizing policy, getting policies submitted and approved, getting rules out, and doing a lot of heavy stakeholder engagement and outreach so that once those letters go out in September, folks have the information they need to prepare and understand the final policies that they need to be compliant with. And then I'll call out December. We anticipate December to be the first month that individuals have to demonstrate compliance. So in other words, if you're new and applying for Granite Advantage starting in January 27, December would be the month that you need to demonstrate compliance. So some states may do a longer, look back prior to December. We anticipate we'll just be doing December based on the state legislation.
So I'm trying to breathe.
Yeah, no problem, yeah.
And this is not a judgment on the state because I understand exactly what you're working with. This is not viable for us to support. This time frame will not be viable for us to support members to prepare, for us to gather the information. We don't know. Do you want us to tell you every month that they're meeting work requirements? You don't know.
Well, so it's not as big as maybe as you think it might be, because there'll be, sort of like ex parte, ex parte being a term, for those that may not be familiar with it, is when we have information that tells us we have enough to know. Typically, it's financial eligibility that they meet the eligibility criteria, but we don't have to go out and ask them. So in the work requirements, there are exemptions, exclusions, that if we have information to determine, like, for example, pregnancy is an exclusion. So there'll be different things, and this is one of the hot areas that is in development, CMS level, state level, is kind of looking at issues like frailty. Will people who have severe mentally ill conditions automatically qualify so that they won't have to do that? So those are all the things that we're working on right now. There are other conditions that besides if you're in SUD treatment, but we don't understand yet what level of SUD treatment do they have to be under. So I think a lot of the people that may be a real challenge for you who have a mental health center, they may automatically be able to be ex parte determined based on the fact that we have information where they're in that category of eligibility already. So I think we need to sort out a little bit more of the end of the universe that I need to support one small thing.
That's helpful. It's very helpful. It lets me breathe a lot easier. In fact, I can breathe now. But I would just ask this, and I ask it at each time we have this conversation, and I hope I'm asking it on behalf of everybody who's supporting and advocating, family members or individuals that they serve and support and work with. If I have to do it for 10 people versus 10,000 people, I still need an infrastructure and I still have to train all my staff. So I just need that lead time, and I know we're not really gonna get it, because it's just the way that the cycle works. But just please keep that in mind, like, you need a year to stand it up. They said they were coming in March with information, now they have come in June when they have their deadline, but I need the window too.
Let's put it this way, it's a very tough deadline to meet. I mean, imagine you have to change your IT system, but you don't have the requirements in the rule yet. So it's really a 6-month window, effectively, or a 7-month window to build out the system changes, do all the communication, do the trainings. And there's certainly something we're meeting multiple times a week with, the mom states, with CMS and so forth to figure out what needs to be done. CMS itself is given an unreasonable time.
I understand.
As well. So they're trying to, like, for example, we normally buy the system rather than identify, you say, what the system will need to do, so you can begin to start to design something. But it is gonna take a team effort.
We will do it.
We'll find a way.
Thank you.
I can't quite see who's hand raising, so if you are, please, Kathy.
Kathy? Kathy, you're on mute if you.
Yeah, clicking on the chat.
There you go. Okay.
I don't know where SBA is.
Can you repeat yourself?
I did, I don't know what SBA is.
State plan amendment. State plan amendment.
Yeah, just to
What?
run through the,
Oh,
State-
plan. Okay, I
Amendment.
heard that.
Thank you for calling us on it. We're trying not to.
yeah, GNC is Governor and Executive Council.
Thank you.
And
I just can't, I just don't think in acronyms.
no problem,
We
yeah.
try, we honestly do. Sometimes it gets away from us. We're having a rough time.
Kristen, you mind just clicking on the chat?
Yes, it's probably the same two that I haven't.
Okay, great.
Also, David Chorney just joined us, so everybody knows, since we've already done introductions.
The visual of the owl is super wonky, so.
Yeah.
They're looking like up there,
Oh,
not
you
down
know,
here.
Other questions, comments?
I think you might like to hear about rural healthcare transition.
Yes, we would.
Since David's here, take advantage of it. Mike, maybe just introduce you to the role and start.
Yeah, so David Chorney was formerly the Deputy Medicaid Director as of, I don't know the exact date, but at some point in February, became the Director of Financial Sustainability and Policy under Go North, which is the Governor's Office of New Opportunities and Rural Transformational Health. And it's to implement and execute the state's Rural Health Transformation Plan. The Rural Health Transformation Plan is it's a federal grant program. It was passed under the One Big Beautiful Bill, or HR1. And it was a large grant program, $50 billion nationwide. New Hampshire, for the first, it's a 5-year grant for the first budget period. Just for the first year of the grant, was awarded $204 million. So in total, it could be just over $1 billion over the term of the grant. And it is really to invest in rural healthcare to increase access, financial sustainability of safety net organizations, innovative care models, the adoption of technology by rural healthcare facilities, and strengthening the rural healthcare workforce. And I think the big piece of news up late, we brought the first rural health transformation contracts to Governor and Council last week on March 4th. And those contracts were tabled because they wanted a little bit more time. I think we've seen that before with the managed care contract where they don't get the contracts until the Friday before the meeting. And there was 5 of them. They're long, it is a lot of money. They wanted a little bit more time. And I believe the governor is scheduling a special meeting, I think on the 16th. It may be official, it may to be scheduled. The tabled contracts and have some further public discussions around them. The first contracts that went to governor and council last week are sort of the foundational contracts through which the state will implement the rural health transformational plan. And there are 2 contracts, one with, there's 5 in total. 2 of them are on workforce development, one with the community college. And that's really geared at starting career pathways at the high school level with career ladder opportunities and supports up through the associate degree level. And then with the University of New Hampshire to extend the career ladder up through graduate degree level to implement clinical simulation statewide, and particularly in rural areas through fixed sites and mobile clinical simulation, and to establish a governor's health scholars award program through which someone could obtain a necessary degree or credential and then commit to practice and get an award to pursue that credential and then commit to practice in a rural area for 5 years. And then there's an access and financial sustainability hub or foundation through the Foundation of Healthy Communities. And this is really to help rural providers, rural communities adopt or have better access to care. So bringing access to care through specialty telehealth arrangements, different care models, mobile integrated health, and then providing supports to providers to adopt value-based payment models. And that could be anything from the technology to better understand the population health of the patients, or increase workforce recruitment and retention initiatives so that they can increase capacity to be able to serve their patients and avoid the patients having to go to the ED. And then there's a community mental health initiative for the CMHCs, which is to expand statewide adoption of the Certified Community Behavioral Health Clinic model, which is a care model that integrates SUD and coordinates with primary care, and also has a value-based payment or alternative payment methodology that ties reimbursement to reasonable costs. And then there's a capital improvement initiative with the Community Development Finance Authority. And this is to, under the RHT program, states are allowed to use money to make renovations at rural healthcare facilities that are tied back to the state's rural health transformational plan. And so 2 of the projects we got approved for with CMS are for county nursing home renovations at Merrimack County and Coos County. And those both tie to the financial sustainability of rural hospitals and rural hospitals in general with to reduce barriers to discharge because there's not enough capacity in the community for nursing care. So I think there'll be a lot more to come. We're really at the initial stages now, and then working with GNC over this week and the coming weeks to these initial contracts through.
So excited.
Yeah, it is. Yeah, and I think I've been looking at other states and reading about how other states are trying to implement it. I think it's unique in New Hampshire that we could actually, with this money, touch the whole state, where if you look at some bigger states that got large rewards like NIC or Florida, it's just very different in how they'll use $1 billion.
Yeah, I like the thinking about, the county nursing homes, so you're downstream, but you're creating access upstream in those rural areas,
Yeah.
hospitals, and, I like that, that's good thinking.
Questions? Let's see anything in the chat.
Could you, this is Karen Rosenberg. I'm just curious. I don't know a lot about value-based payments. Can you explain what that is and how that could positively impact access to healthcare for folks?
I think it's probably, to do it justice, could do 2 minutes, but I think basically it's trying to better align incentives for both quality and cost, and that some of the savings that come from improving quality and managing costs. So for example, one of the things when we were doing rural healthcare transformation, we looked at the demographics in Coas County, that the rate of congestive heart failure hospitalizations is like, I think, 10 times the state average. So to the extent that in a regular system that was improved and reduced it, that would improve quality, but the cost savings, none of it would accrue to the providers. In fact, they would be negatively impacted by that versus a value-based program. There'd be some benefit to both improving the quality of care, meaning fewer hospitalizations and congestive heart failure, but also some participation in the savings. But I think to do it justice, we would need more time. Hopefully that example helps a little bit.
It does. Thank you.
Dr. Joan Greco.
Hi. We're really excited about the work ahead with rural health transformation, but was curious about kind of that next level of how we're going to engage key stakeholders in this work to create really meaningful and sustainable programs.
There will be a lot of meetings coming up, and each of the hubs will be doing, you call them procurements or competitive procurements or requests for applications that would engage local stakeholders. I think the big thing we're really focused on is making sure there's provider and community buy-in for the investments that get funded through the hub, so that things aren't funded in silos. So there will definitely be a lot of stakeholder engagement, especially in the workforce development pieces too. I think something that's a little bit missing when we look at workforce now is sort of the linkage between the education institutions and the providers that need the graduating students. And so trying to support those linkages as well.
Great, thank you.
Other questions, comments on rural health? Okay. We're a little behind schedule, so we can keep moving.
So do you want to maybe select from areas in the updates list that actually have something
So we have
meaningful to report?
enrollment and
I
eligibility.
could send that.
Yeah, Henry, would you be okay with us, just since we're short on time, sending out the enrollment eligibilities? That goes right through, and then we'll go to department updates for our remaining time.
I have to leave projects.
Okay. All right, so we're gonna move to department updates. Dr. Chang, is there updates you want to share on the adult medical program?
Morning, everyone. With consideration of time, I'll just do a very quick overview of the current status of the adult Medicaid program. At the current time, eligible member, we have around 81,000. And we have unique member access dental benefit around 28,000. And up to this point, from April 1st, 23, claim received its 111,000 claims. At the current time, 227 unique provider and 132 unique location. And we do have a mobile dental service. And so far, we have provided 362 events, and we have served 4,400 patients. and they go around to different location of the states. From the beginning of the program, we have mobile van that will go around to the state 2 days a week. And we have increased that to 5 days a week. That's a really quick update. Are there any question or concern you have?
Thank you so much.
Oh, Jill?
Don't go for it.
Sorry. Yes, in the Rural Health Transformation Grant for looking at workforce, are you looking at some additions to the provider network?
Yeah, definitely. That's a big piece in the plan. There's intention to increase residency present in the state, possible rotation for dental students that rotate to the states. Hygiene is going to be part of that plan as well. I think David will have more information than I do, but it's definitely something that we're working on. Also specialty care. I don't know if the group know that chronic shortage of oral surgeon in New Hampshire is something that we definitely want to address.
Great, thank you.
Anything to add, David?
No.
Good question. Okay, thank you, Dr. Chang.
Thank you.
Do we have Scott?
Yes, Scott.
DDU updates?
Of course.
Yes, good morning, everyone. Sake of time, I can make this, I shortened it as you can see from my normal one regardless. So for the adult cases, we have for the month of February, 199 pending. A total of 15 cases were over 90 days. Out of the 109, were in write up. For the children's cases, 38 pending, 5 over 90 days, and 7 were in the final stages in the medical review team write up. Of the 15 adult cases over 90 days, they were due to the providers not responding timely, meaning we had to send more than one notice out to obtain the records. And the same thing with the 5 HCCSD cases that were over 90 days. For the month of February, we received a total of 132 new applications. Our overall timeliness for the month of February was 92%, and the cases that were within our control, we were at a 99.5% timeliness, which is amazing. Big kudos to my staff and the medical review team. Just, even being down on staff, streamlining in the high 90s for timeliness.
Thank you, Scott.
Yes, absolutely.
Next.
Sorry, we hit rural health transformation already. So Carolyn, I'll reassure you.
I can just give a very brief number of current participants. 221 active adults, youth, there's 16 and in the both category, there's 4, so a total of 241 current participants in the community reentry demonstration for the 1115. And we are implementing in the county jail in the next few months. In Merrimack County is our first county jail, and that will be for adult and youth reentry.
Okay. And then we're continuing to link the HCBS spending plan landing page here.
And we're in the phase of wrapping up the finances of that.
Yeah, winding down.
The latest report that we got CMS came back in February, so it should be an update.
Yes. And then on the waiver items, I don't have any new updates from prior meetings on R 1915J or 1915I or 1915Bs. And if Carolyn's anything on the 1115, no, okay. And on Medicaid to schools, do we have Heather on this morning?
I didn't see her.
Okay, so I'll share an update there. We're continuing to work with our vendor, Fairbanks, to finalize our state plan amendment submission for implementing the claiming methodology for Medicaid to schools. So that's been our big focus, is finalizing that, and then we'll be preparing in a more dedicated way on working with the schools to use this new reimbursement methodology. And we have the link here to our contract with Fairbanks, who's giving us technical assistance for that implementation. And then we have HE 805. Are there, I know that hearing was rescheduled. Are there any updates that the subcommittee wants to share?
Do we have Carolyn or Kara? Or I guess Joan was on the subcommittee as well.
I don't know if I saw. I don't think, Carolyn, I don't think she was still on. Kara's not on either.
Do you know what happened? I do not know what happened at the public meeting.
We can grab that update unless,
You want me to reach out to?
well, unless Christina, if you happen to know what happened with the 805 public hearing, but otherwise I will collect an update from LCFS.
I don't have an
Oh,
update on that. This is Joan.
Olivia.
Other
could you
than the
rephrase-
discussions that we had earlier in the meeting.
Mhm.
But I don't have
Carol?
an update on. Yeah, go ahead, Caroline.
Oh, no, the public hearing is scheduled for tomorrow at 10 a.m.
Oh,
That's what you're asking. At
Yes, is
the
that the
Howard
Parks
Center.
and Recreation Building?
Okay, I will correct that. Thank you for flagging that. They may have gotten
that's for that.
rescheduled. Okay,
Any other business before we adjourn this morning for 7? Okay, so we can take a motion to adjourn.
So moved.
Second.
All in favor?
I.
Aye.
Bye.
Thanks, everyone.
Thank you.
Thank you.
Thank you.
Bye, thank
Bye,
you.
everyone.